Hello and welcome to Pharmazy's pharmacy teaching videos. This video is going to be about acute coronary syndromes, which is a high-weighted topic for the GPHC exam because it falls under the cardiovascular system. If you enjoyed this video, hit a like and subscribe, and as always, follow our Instagram and Facebook pages for quizzes related to the video. Coronary heart disease is one of the UK's leading causes of death and is responsible for around one death every 8 minutes. It can be classified into 4 categories, so there's stable angina, unstable angina, NSTEMI and STEMI. The latter 3 are known as acute coronary syndromes, which is what we're focusing on today, and NSTEMI and STEMI are known as myocardial infarction with or without ST segment elevation. Patients with different acute coronary syndromes may present similarly, but a definitive diagnosis is made based on the clinical presentation of the patient, ECG changes, and measurement of biochemical cardiac markers. So looking into the pathophysiology of coronary heart disease, this occurs when the coronary arteries, which are the major blood vessels that supply the heart with blood, get clogged up with deposits of cholesterol, and these deposits are called plaques. The pain or discomfort that a patient feels from the narrowing of these coronary arteries is called angina. If one of the plaques ruptures or bursts, this causes a blood clot to develop at the site of the rupture. The clot may block the supply of blood to the heart, and that triggers what's called a myocardial infarction, or a heart attack. Without this blood supply to the heart, the muscle begins to die, and without treatment, the heart muscles will experience irreversible damage. If a large portion of the heart is damaged in this way, the heart stops beating and the patient goes into cardiac arrest. Signs and symptoms of acute coronary syndromes include chest pain, shortness of breath, chest pressure or tightness, pain in the jaw, back and other areas of the upper body, sweating, nausea, vomiting, an overwhelming feeling of anxiety, and dizziness or lightheadedness. Following a heart attack, a patient is usually admitted to hospital where an electrocardiograph or an ECG test is given. This test measures the electrical activity of the heart, and alongside blood tests, it allows doctors to confirm that a heart attack has taken place and also assess the type of heart attack, which will help determine the most effective treatment. An ST segment elevation myocardial infarction, or a STEMI, is the most serious type of heart attack in which a coronary artery has been completely blocked for a long period of time, causing extensive and irreversible damage to the heart muscle due to myocardial ischemia. A STEMI is what most people think of when they hear the term heart attack. A non-ST segment elevation myocardial infarction, or an NSTEMI, is slightly less serious as the supply of blood to the heart is only partially blocked and therefore a smaller section of the heart is damaged. However, an NSTEMI is still regarded as a serious medical emergency, and without treatment it can progress to serious heart damage or a STEMI. Unstable angina has no evidence of myocardial necrosis, however it's that pain that a patient feels when there's narrowing of the coronary artery. A number of other tests can be used to assess the state of the heart and check for related complications. However, because heart attacks are medical emergencies, some tests are usually only carried out once the initial treatment has begun and the condition has been stabilized. But these include blood tests. So, damage to the heart from a heart attack can cause certain proteins or cardiac markers to slowly leak into the blood. And the most common protein measurement that we take is called cardiac troponin, which is elevated when a patient has a heart attack. Chest X-rays can be useful if diagnosis of a heart attack is uncertain and there are other possible causes of the symptoms. It can also be used to check whether complications have arisen from the heart attack, such as a buildup of fluid inside the lungs. An echocardiogram is a type of scan that uses sound waves to build up a picture of the inside of the heart, and this can be useful to identify exactly which areas of the heart have been damaged and how this damage has affected the heart's function. And finally, coronary angiography can help determine whether a blockage or narrowing has occurred in the coronary arteries, and if so, to locate the exact location of that blockage or narrowing. Moving on to drug treatments. Now, this may look like an overwhelming table, but we'll go through it together, and it covers the initial and long-term management of acute coronary syndromes. So to start off with the initial management, which is marked by a tick, oxygen should be administered if there is evidence of hypoxia, pulmonary edema, or continuing myocardial ischemia, regardless of the type of acute coronary syndrome. The pain and anxiety of myocardial infarction is managed with slow IV injection of diamorphine or morphine, and an antiemetic such as metoclopramide by IV injection should also be given. Nitrates are used to relieve ischemic pain. If sublingual GTN isn't effective, then IV or buccal GTN or isosorbide dinitrate is given. Aspirin, chewed or dispersed in water, is given for its antiplatelet effect and to promote reperfusion. And clopidogrel should also be given. Prasugrel is an alternative to clopidogrel in certain patients undergoing percutaneous coronary intervention. So what is that? Opening the occluded artery can be done by percutaneous coronary intervention, or PCI, using a procedure to widen the coronary artery known as coronary angioplasty. And this is done in patients who have had a STEMI. During coronary angioplasty, a tiny tube known as a balloon catheter is put into a large artery and passed through the blood vessels up to the heart using X-rays to guide it. And then it's moved into the narrow section of the coronary artery. Once in position, the balloon is inflated inside the narrowed part of the coronary artery to open it wide. A stent, which is a flexible metal mesh, is usually inserted into the artery to help keep it open afterwards. Patients undergoing PCI should also receive either unfractionated heparin or a low molecular weight heparin such as enoxaparin to help reduce reocclusion. In patients who can't be offered PCI within 90 minutes of diagnosis, a thrombolytic drug such as streptokinase or alteplase should be administered along with either unfractionated heparin for a maximum of 2 days, a low molecular weight heparin such as enoxaparin, or fondaparinux. Patients who don't receive either of these reperfusion therapies, such as patients who have had an NSTEMI, should be treated with either fondaparinux, enoxaparin, or unfractionated heparin. Early administration of some beta blockers has shown to be of some benefit and should be given to patients without contraindications. ACE inhibitors, or ARBs if ACE inhibitors aren't suitable, are also of benefit to patients who have no contraindications, and in hypertensive or normotensive patients, treatment with an ACE inhibitor or an ARB can be started within 24 hours of the myocardial infarction and continued thereafter. So that's all the initial management. In terms of long-term management, so for the prevention of further cardiovascular events, aspirin should be given to all patients unless contraindicated. The addition of clopidogrel has also been shown to be of benefit in reducing morbidity and mortality. Prasugrel or ticagrelor are alternatives to clopidogrel in certain patients, but for those intolerant to clopidogrel and who have a low risk of bleeding, the combination of warfarin and aspirin should be considered. Aspirin should be given indefinitely, while clopidogrel is usually only given for 12 months. So dual antiplatelet therapy for 12 months, then continue with aspirin alone. Beta blockers should be given to all patients in whom they are not contraindicated long-term. Also, an ACE inhibitor should be considered for all patients. If an ACE inhibitor can't be used, an ARB may be used for patients with heart failure. So again, this is a long-term treatment. Statins also have a role in preventing recurrent cardiovascular events, and nitrates are used for patients with angina. So often you'll see that they're given GTN spray. So that's both the initial and long-term treatment of acute coronary syndromes. And finally, patient counselling to reduce the risk of further cardiovascular complications. So it's important to give your patient healthy living advice, including smoking cessation advice, and this may be done through community pharmacy services, diet, weight management, and exercise advice. But bear in mind with exercise that once a patient returns home after a myocardial infarction, it's usually recommended that they rest and only do light activities. Gradually, they'll be able to build this up. However, how quickly they do this will depend on the condition of their heart and their general health, and their rehabilitation program should give a range of different exercises depending on their age and ability. Most of the exercises will be aerobic because they're designed to strengthen the heart, improve circulation, and lower blood pressure. You might also give your patient advice on diabetes and blood pressure management, as well as medication counselling. So a side effect of ACE inhibitors is dry cough, for example, or that they should report muscle pain if they develop this whilst taking statins, or that they shouldn't take NSAIDs over the counter if they're taking ACE inhibitors, for example. And give your patient medication reassurance and stress the importance of adherence. A lot of patients will be started on 5 new drugs in one go, so aspirin, clopidogrel for a year, ACE inhibitors or ARBs, beta blockers and statins. Stress to your patient the importance of taking these, as well as how to take them and why they're taking them. Be aware of reported complications. So if a patient presents with palpitations, chest pain, dizziness, fatigue and breathlessness, could this be a sign of arrhythmias? If they present with swelling in the arms and legs due to the buildup of fluid and shortness of breath, could this be heart failure? And also be aware of signs and symptoms of depression and anxiety. Having a heart attack can be really frightening and traumatic, and it's common for patients to feel anxiety afterwards. For many people, the emotional stress can cause them to feel depressed and tearful for the first few weeks after returning home from hospital. And if those feelings of depression persist, then they really should speak to their GP, because more serious types of depression often don't get better without treatment. And remember that the emotional state of a patient can also have an adverse effect on their physical recovery. So that's all for acute coronary syndromes. We hope you found this video useful. As always, please feel free to leave your feedback and comments, and keep an eye on our Instagram page for a quiz related to this topic. If you'd like a handout of these slides, then drop me a DM on my Instagram page and I'll be sure to send those over. Thank you.